Sidana is a urologist, and Dr. Struve, who is a radiation oncologist, and become more informed about your choices. And we know that for prostate cancer, we have choices. It can be part of the problem rather than part of the solution. Can be so many choices, and so they can really help with that. And I think tonight the subject of the presentation is focal treatment. I'm not sure where Dr. Struve fits in with that. Maybe
more broad topic.
More broad topic. Personalized, okay, focal therapy, multidisciplinary clinic, and prostate cancer clinical trials. We cover many bases, so we're really looking forward, and thanks you guys very much for coming tonight. You're very busy, you have a lot on your plate. And,
give a hand. Thank you, Jim and Ethan and Tom, for inviting us over here. Thanks, everyone, for coming today. Me and Dr. Struve have been working together over the last 2 years to establish something called personalized prostate cancer care at UC. And we're slowly building up, one step at a time. And we started with multidisciplinary clinic, then we went to focal therapy, now we have more prostate cancer clinical trials. And the reason we need, as you brought up, there are too many options, right? There are too many choices. And that's why for every prostate cancer patient, the care is very individualized, personalized care. One treatment would not be the best treatment for all 50 of you guys, okay? So, what is this?
Why have to turn it on?
Jim?
Okay. I don't have any disclosures. So every year, as you know, 180,000 new prostate cancer cases. But prostate cancer is not a single disease. It's multiple different diseases. Everybody has very varied presentation. Cancer has varied degree of aggressiveness. We have recent 6 prostate cancer, which is probably not going to kill anybody for 30 years, right? And then we have recent 9. And we have patients recently in our multidisciplinary clinic who have progressed from PSA of 10 to PSA of 180 in 6 months, and now have rectal invasion and metastatic disease. So there is that kind of prostate cancer to extreme severity, extremely aggressive. Different levels of sexual function and urination issues. Some people don't have any erections, while others have very strong erections. Some people don't have any urination problems, others have severe urination problems. So, and different levels of it. And everybody has different expectations. Some patients are okay with not having erections after the treatment, others are not. There are patients who walk into our clinic, I'm pretty sure Dr. Struve can say also, they said, I would rather die than lose my erection. We hear that stories all the time. And then there are other patients who say, I want to live, I don't care about my erections. So does one size fits all for prostate cancer patients? No, right? Very, very varied presentation, very varied aggressiveness, and very varied expectations. So because of that, there are multiple choices, and we can't treat every prostate cancer patient the same way. Before we started this program at UC, if you go to surgeon's clinic, you are getting radical prostatectomy. If you go to radiation oncology, you're getting radiation. You go to urology group, you're getting cyberknife. Just limited options. What that facility can offer, you're getting that option. You're not getting all the options. So that's why we're trying to build upon this program, and we expanded it to 4 things. We started with prostate cancer multidisciplinary clinic 2 years ago. Then we started focal therapy of prostate cancer 1.5 years ago. Then we started cancer survivorship clinic and had the integration in our program of cancer. All of my prostate cancer patients go directly to cancer survivorship now. And then we recently have also started opening more clinical trials for prostate cancer. So it starts with prostate cancer multidisciplinary clinic, and I think we've talked about this in the past. It's the first such clinic in greater Cincinnati area. There was nothing like that 2 years ago. And our providers are urologic oncologists, radiation oncologists, medical oncologists, GU radiologists, GU pathologists, urologic nurse practitioner, and cancer survivorship nurse. So all of us sit together and review in depth all the history, physical, previous pathology, previous imaging, previous treatments, and come up with a combined plan. When there are so many providers involved in that plan, the risk of bias is very, very low. And that's the whole premise behind this clinic, unbiased information. Most of our patients from multidisciplinary clinic over the last 2 years, we have seen hundreds of patients. We have probably treated less than 10 of such patients because this clinic is more for information, not for treatment. We can't even treat from that clinic. It's just providing information and giving the options, and patients choose their own options. It's one place to get opinions from multiple providers at the same time, and it's especially good for complex prostate cancer scenario. You can't sometimes, as a surgeon, I'm a lot of time not exactly clear what's the best option, and then instead of grabbing Dr. Struve 2 days later, he's sitting in front of me in that clinic, and I can get his opinion at the same time. So it's very good for those complex prostate cancer scenarios. Advanced prostate cancer, cancer very aggressive where surgery alone may not be enough or radiation alone may not be enough. And it's a nice integration into the cancer survivorship. Patients see the cancer survivor nurse in that clinic, so after the treatment, it's easier to transition to cancer survivorship instead of just like we reminding patients 6 months later that you need to go to cancer survivorship. And cancer survivorship for prostate cancer has proven benefits. And it also offered as a platform to offer new treatments and facilitate research and teaching and using. So that's the first fruit for the multidisciplinary clinic, focal therapy for prostate cancer. This is a treatment, as most of you guys have heard, that aims to eradicate only the known cancer within the prostate and preserve the uninvolved prostate. So the theme is if there's uninvolved prostate tissue which is not damaged, the side effect profile will be lower. It's considered equivalent to a male lumpectomy that just adequately treats the disease and preserves the quality of life. And the hypothesis here is if you preserve prostate tissue, you'll preserve functional outcomes. And it's possible because the multi-parametric MRI. This is a photograph from the famous JAMA paper, and you can see how good the lesions are visible on prostate MRI, and with the help of Dr. Verma at UC.
Can you go back one slide for the new guys and talk about the male lumpectomy, because that's really new.
Okay.
So what they're trying to do there?
So typically, and I've given like longer presentation on focal therapy in this group, so that's why it's just a brief presentation for focal therapy. But typically, if you remove somebody's prostate, even with aggressive prostate cancer, most of the time we look at the specimen, less than 20% cancer, 80% benign. 15% cancer, 85% benign. At the max, you would see 25-30% cancer, 67% benign. So the question is, do we have to remove the entire prostate if most of the prostate is usually benign? But before MRI era, there was no way to visualize prostate cancer. You cannot find prostate cancer specific location in the prostate. So if there was cancer found on a biopsy, the treatment was to either take the entire prostate out or to radiate the entire prostate. But over the last 10 years, MRI has helped us found the cancer in the prostate. And if we can prove it, if that's the only area of cancer involved, then we can reliably destroy it and not have to treat the entire prostate. When we don't treat the entire prostate, we preserve the function. We preserve the sexual function, we minimize the side effects of urination. And that's where the hypothesis behind focal therapy is. And there are various ways to do it. But the one thing which is common among all focal therapies is MRI. MRI and ability to visualize prostate cancer. If you can't see it, you can't destroy it. There are various ways. You can get freezing, you can get HIFU, you can get laser. There are multiple treatment options for that, and there are multiple clinical trials. Nobody has proven which one of them is better than other. But in terms of side effect profile, there are some differences. And we'll discuss briefly. So this is one of the recent paper came from Hashim Ahmed and Mark Emberton. These guys were the pioneers of focal therapy in urologic world. And they started doing focal therapy when people didn't even believe in MRI. And actually everybody kind of criticized them for just doing poor medicine. It's in US, because in US urologist wanted to just take the prostate out. Anybody prostate cancer, prostate comes out, right? And in London, they were changing things. They were trying to do different things, and the urology world in US did not believe them for several years until the outcomes started showing up. So this is one of the recent paper where they evaluate all their patients, 1,000 patients, which underwent some sort of focal HIFU or hemiablation. Hemiablation means destroying half of the prostate, leaving other half which is not involved alone.
Explain HIFU for the new guys.
Yeah, HIFU is a treatment modality. It's called high intensity focused ultrasound. So in this treatment, we put an ultrasound probe in the rectum, like the similar ultrasound which is used for biopsy, but different strength, different frequency. And it sends sound waves into the prostate and burns prostate tissue. It raises temperature to 80 Celsius. At 80 Celsius, no human body cells can survive. So it's very accurate, it's very pinpoint. The destructions are pinpoint by pinpoint by pinpoint. So it's a little bit slow in destroying, but it's very accurate. And since we achieve very accuracy in destroying cancer and not destroy the uninvolved tissue around it, the side effect profile is minimal. At UC, we offer HIFU, and I'm going to talk about UC's experience in a little bit. But this is one of the older series. I think they analyzed all the patients who were on different clinical trials and clinical care, and they were evaluating their somewhat long-term outcome. It's still short-term outcome for prostate cancer, but you'll see the outcome is slightly.
You said that this is reported from the United Kingdom. Is it available in the United States now also?
HIFU? Yeah. We have at UC. UC is the only center in like 100-mile radius which has.
And when they mention Gleason 7 or higher, what's the status of metastasis in this group?
UC. So the median follow-up per patient 36 months, and a lot of these patients got biopsy because it's a focal procedure. You're destroying only part of the prostate. But you still have 60, 70, 80, 90% of prostate completely untouched. If something happened in that 10-20% part of the prostate which caused cancer to form, it can happen in the 90% of the prostate too. So a lot of these patients got biopsies. Some of them did not, and because they said, no, our MRI looks good, we're not going to get biopsy. But a lot of these patients got biopsy, and 24.7%, which is 25%, had cancer on repeat biopsy. So it's not a great technique to get rid of all cancers. And that's what we need to understand. Do we really need to get rid of all cancers? Right? Do we need to get rid of the cancers which are causing harm and in 10, 15 years will cause metastatic disease? And around 26 needed deep treatment. But the most important thing is only 7% needed radical treatment. 7% radical treatment was either surgery or radiation therapy. 3% needed treatment, but a lot of them needed just repeat focal treatments. Freedom for biopsy failure was 54% 8 years. At 8 years, there's 50% chance that you're completely cancer free for a procedure which has minimal morbidity. It's almost like an outpatient procedure. Get done in 2 hours, go home, you don't feel anything. Still 50% chance that you're done with cancer. So these numbers, if you compare it to radical prostatectomy, they don't look impressive. But radical prostatectomy is probably a dozen times more morbid and more invasive procedure than a focal HIFU. But I don't think I have. Actually, I do. So freedom from radical treatment was 81% in 8 years, and their survivals were close to 98%, 10-year survival. But that's with every prostate cancer treatment. So it's not that they made it any better or worse because the outcome was the period was so short. So you see, we started focal program. We initially started with focal cryo because that's covered by insurance, and now we have HIFU, and we are the only center in 120-mile radius which has HIFU. HIFU is not covered by insurance. It's close to like $8,000, $15,000, something like that, for people to get treated with HIFU. But the most important thing about these focal treatments is we need a motivated patient. It's not a treatment for somebody who wants to just get one treatment and forget about it and not see doctor again. And the reason is we're treating only 10, 20, 30% of prostate. 60, 70% of prostate is still there. And actually, most of the time you have some degree of cancer in that prostate. Just because we didn't find it doesn't mean there's no cancer. So we're treating the more aggressive cancer, the cancer which might cause you problem in 5, 10, 15 years, but there's lower aggressive cancer, which is Gleason 6, still in your prostate somewhere, we just didn't find it. That's why it's important to have a motivated patient who continues to visit us and keeps getting PSAs, MRIs, and periodic biopsies. So eligibility criteria and UC is MRI fusion biopsy demonstrating Gleason 7 in MR visible lesion. So a lot of my patients who have single-sided cancer on systematic biopsy, MRI confirms that there's a lesion there, they want to get focal therapy. But we've been so rigid in making sure our criteria are met because the risk of failure from this treatment is very high to begin with. So you want to absolutely make sure the patient is a focal candidate. So those patients get repeat fusion biopsy to confirm the cancer is limited only to the MR visible area and there's no cancer outside of MR area. So if MRI shows a lesion, a cancerous area, we have to absolutely prove that's the area of cancer and there's no other cancer. And there should be an absence of Gleason 7 or high volume Gleason 6 outside of the planned treatment area. And that goes by saying we're not going to leave a 7 behind. PSA should be less than 20. And the whole goal of focal therapy, and patients ask, why can't I get bilateral focal? The reason we can't do bilateral focal is that defeats the whole purpose. Unilateral focal, unilateral means one-sided, bilateral means both-sided. When we do unilateral focal, we are inducing some damage to the nerves. If we do bilateral focal, we're inducing damage to both nerves. Then, as well get the prostate out. The advantage of focal therapy is we can avoid damage to at least one nerve and avoid damage to urethra and the sphincter. At UC, we offer cryoablation and HIFU. And these are some outcomes. This is somewhat older paper. Now the numbers are probably higher. But if you see the cryotherapy numbers, there's 4 to 25% biopsy positive rate. And HIFU is somewhat comparable, 0 to 21%. IRA is a little bit higher, and that's because it's IRA is irreversible electroporation, and it's the current flows through prostate and burns the prostate. A little bit higher. Laser has the highest failure rate. And again, laser is not a great modality to destroy prostate tissue, but when the focal therapy first came into existence, laser equipment was the only equipment which was MRI compatible. So you could use laser in an MRI tube. Now, because we have fusion equipment where we can use MRI information outside, we can use MRI information right here to target cancer, right? So we don't have to go to the MRI tube. Now we can use the same information and different other modalities, cryo, HIFU, photodynamic therapy, brachytherapy, and IRE to do the same destruction as laser was doing in the past. So that's why laser has fallen out of favor. Laser has a little bit higher positivity rate, but the side effect profile of laser is definitely lower than cryo, because cryo, which is freezing, forms ice balls, and you can't control the size of ice ball as well. So it forms big ice balls, and they may destroy surrounding tissue, while laser, like HIFU, is a very pinpoint destruction. It's very, very accurate destruction, so the side effect profile is lower in laser and HIFU.
According to that, the brachytherapy is just about, if not better than the HIFU, correct?
Yeah, you're right. Brachytherapy, but it's still the radiation. So the advantage of the top 5 is those are all surgical modalities, so they don't have any long-term complications. Brachytherapy is still radiation. So you still have long-term complications. You have the potential of having long-term complication, and the risk is low, but there is still potential of radiated tissue staying in the body and causing long-term complications.
And this is just based on that sample you mentioned before of Gleason score of 7, correct?
Most of them, I think a lot of them were Gleason 6s. These are early era experience with focal therapy. When people started doing focal therapy early on, they were using a lot of Gleason 6s for focal therapy. They were not sure if they were doing patients a favor or not.
But you'd say probably none of these patients are Gleason 9 or 10.
No, none of them are Gleason 9 or 10. They are all Gleason 6s and 7s. Okay, so this is, and cryotherapy initially was not favorable because again, it forms big ice ball. Destruction is really effective, but destruction goes beyond the borders, right? And when it goes beyond the borders, your risk of damaging the nerves, so your side effect profile is going to be higher. Cryotherapy is covered modality, but it's not as pinpoint as HIFU and laser and other modalities. So at UC, what we started doing differently, and we're the only few centers in the country and in the world where we use freezing by this modality and trying to decrease that side effect profile of freezing even more by making it very accurate. And this is a brief video I had for a conference because this is a new treatment which I think there are only 2 centers in the country have been performing using Artemis fusion system. So this is a machine which incorporates prostate MRI information into the operating room ultrasound. Okay, so we don't have to do this in the MRI tube anymore, and it scans the prostate using ultrasound, scans the prostate from the MRI, and then creates 3-dimensional model of MRI, 3-dimensional model of the ultrasound. It's put the 3-dimensional model onto the ultrasound, so the lesion, and this is just making the 3-dimensional model, so that 3-dimensional model fits perfectly like it was in MRI. And if you see that red area along the green border, the red area is the cancer, and the green border is the area of destruction. Now, because it's so accurate by using MRI information, we're able to limit our area of destruction to that area. So this has definitely limited the side effect profile of focal cryo. Focal cryo, to begin with, has very low side effect profile. By using fusion technique, by targeting only the MR-based area, we have lowered the side effect profile even more. Again, it's never going to be the same as HIFU or laser therapy in terms of side effect profile, but we're talking about very low side effect profile to begin with. We're talking about 1 to 2% risk of side effect profile versus maybe 0.2% less. And this is, I tell all my patients, it's a difference between Mercedes and Honda. Nice Honda Accord. Both of them drive really well, but if you can afford Mercedes, yes, get HIFU done. But this works the same way as HIFU.
What's the case of prostate cells after ablation? Do healthy prostate cells regenerate at all?
No. So in that area where we ablate, there's just scar tissue. There's a stromal fibrosis. So prostate has something called stroma, which is kind of similar to scar tissue, collagen, and it has glands. Glands is the one which forms cancer. So after we ablate, in that area there are no glands. There's just stromal fibrosis. So these are some of the templates which we use. So either there is big, large, that reddish cancer, which is a bigger index lesion, and there's very, very small cancer on opposite side. So we offer focal therapy for those patients because, as we discussed, Gleason 6 prostate cancer is not going to probably matter much for 10, 15, 20 years. Very rarely, and I never do this, but other people do that also. Even if there's smaller, significant cancer, that yellow cancer, even if there's smaller, significant cancer, which is Gleason 7, they will leave that alone also and destroy the big cancer. So at UC, we don't do that. We do not leave any Gleason 7. If you have Gleason 7 on both sides, then you're not eligible for focal therapy. And if you want to destroy a little bit more, to be on the safe side, these are more quadrant ablations. These are called partial plaque. So they're not pure focal. For example, patients who are not getting, who don't have MRI, or places where there's no fusion capability, the machine which I showed you, if they don't have it, they put the freezing probes into that area and just destroys the wide area. Again, the more you destroy, the more the side effect profile. So this was actually old data We haven't collected the new data, but these are our first 11 cases, and if you see every single one of them is 7. There's no 6, there's no 8, 9, 10. And over their change in PSA was 60% at 3 months, and their SHIM score, which is Sexual Health Inventory score for men, tells us how good their erections are. A lot of them, because it's a treatment I offer for patients who have erections, right? If you don't have erections, you do not care about erections, probably you don't need focal therapy. You can just destroy your entire prostate using hypo or freezing, and you'll be still fine. This is treatment for most patients who have good sexual function and they want to keep sexual function. So over 6 months, our decline in sexual function was only 4 points. And in terms of symptom score for urination, it didn't change significantly at all, just 1 point increase in symptom score. And in terms of absence, all my patients get biopsy at 6 months, every single patient. They get MRI and they get biopsy at 6 months. They have 83% cancer free. But again, a lot of them will fail in future, and over 5 years, I think it's going to look similar to what the London data is. 50 years failure, 50% failure, 50% success. But even if there's a 50% failure, the advantage of focal is it does not burn bridges in most scenarios. Yes, it makes surgery more difficult, but radiation options don't change at all. The whole gland ablation options, ablation means HIFU and cryo, they don't change at all. If your cancer comes back, you can still get a complete destruction of prostate using freezing, or complete destruction of prostate using HIFU, or get radiation treatment, or can get seeds, or can get surgery also. Surgery will be a little bit more challenging though, and with higher side effect profile. So surveillance after focal therapy, and that's important. Every patient gets focal therapy, they're really happy with their side effect profile, they don't feel anything, PSAs go down, and nobody wants to get anything else done after that. But that's why in our literature, there's great emphasis being made to only recruit motivated patients, because surveillance is very important for focal therapy. And the reasons are PSA becomes less relevant. There are patients, one of my patients had 90% PSA decline. He had PSA 5.7 dropped down to 1. I did an MRI, was read negative by radiologist. It was not Dr. Verma, some other radiologist read it negative. I still went ahead and did the biopsy, came back as Gleason 7. Reviewed it with Dr. Verma, and then in hindsight she says, yes, there's something there. So MRI was probably not negative. But again, if this was a standard radiologist, MRI negative, PSA 1, I would have left that guy alone, and he would have Gleason 7, which would have kept growing for years and years. And since we caught it early, the volume was low, he underwent other focal therapy treatment, and he's doing fine now. So PSA has some correlation, but it's not the only marker. Your PSA might decline significantly, but you might have still residual cancer there.
If your PSA rises, though, is that significant?
Even that's not significant. I had a patient whose PSA did not budge at all, and I was really worried. Did an MRI, there was cyst in, the destruction was so effective that the body formed a cyst in that area, and that was leaking PSA. Did biopsy, came back negative. So I've seen both ends of the spectrum. Even in like the short 80-90 patients we've done, we've already seen both ends of the spectrum. PSA didn't change, no cancer, and PSA dropped down 90%, still cancer.
One of the things, you've been mentioning PSA a lot, but you haven't mentioned testosterone. If a person has been having, the androgen deprivation therapy, that tends to shrink, I think, the size of the prostate. Does that make focal therapy more difficult then?
So these are 7 patients, right? Localized prostate cancer. We won't have to worry about androgen deprivation therapy ever in these patients anyways, right?
But I meant if they had it before the focal therapy, is that a problem because it reduces?
They would not be eligible for focal therapy. If there was ever a reason to get androgen deprivation therapy, that's not a focal therapy patient to begin with.
With the exception of maybe focal salvage.
Exactly. Focal salvage might be different, yes. People who got ADT because of radiation for 2 years and then had recurrence, and now they're getting focal therapy. Yes, they had prior androgen deprivation therapy, but that doesn't change anything in terms of focal. We're dealing with smaller glands, But other than that, it doesn't change anything.
So it does make it harder to focus on a small area.
No.
Can I ask a quick question also about salvage and the salvage setting? What about the other kind of salvage where you might want to get radiation post-focal, and there's a lot of fibrosis there? Now, when you use spacer or want to try to use spacer, does it make it more difficult to inject the spacer because of the fibrosis? Is that a concern?
Not that I'm aware of. I think people have had that concern about the ability to open that space after it's been violated.
Right.
But with the cryo, correct me if I'm wrong, Dr. Sidana, but you do a transparent neomy, meaning he goes through the skin between the scrotum and anus and inserts the needle into the prostate. And then with HIFU, the temperature between the rectum and the prostate is actually really, really low. It's not until you get to the focal point of the ultrasound that the temperature gets very high. So the space that the spacer goes into shouldn't be disrupted with either cryo or HIFU.
Okay, thank you.
I think a lot of that is varied also depending on the lesion. If there's an anterior lesion, then there's no disruption at all. Anterior lesion means like above, like away from the rectum.
Sure.
Posterior lesion means close to the rectum. If for some reason somebody has very, very posterior lesion and we destroy that with freezing and HIFU, yes, there will be some problem in that area. And spacer may or may not be easy. But if there's anterior lesion, that should not change anything. Okay? And the other reason is PSA is not reliable because we don't have data. Like this is, we're talking about 8-9 years of data, which is nothing in terms of prostate cancer follow-up. For surgeries and radiation, we have data for the 15 and 20, 30 years. With these things, we have data for 7-8 years. So just relying on PSA is just not safe. And that's where multiparametric MRI comes into the picture. It gives the patient, the clinician, the ability to first follow up the uninvolved prostate tissue, like undestroyed prostate tissue, and also gives us ability to follow the tissue which was targeted and destroyed. Now, the issue with that is your radiologists have to be really, really good. Not every radiologist, like even at UC, when I do focal cryo, after being burned a couple of times, I've asked now Dr. Verma only reads my MRI. Because you have to be very, very specific to look for these things. Not many people are getting focal therapy, and so the radiologists don't have that much experience of reading those MRIs. But somebody who are like the experts, considered experts in MRI, like Dr. Verma or other radiologists around the country, they should be the one reading these MRIs, at least for now, until everybody catches up. So MPV MRI is definitely needed after prostate focal therapy, and most surgeons are now getting that at 6 months. And this is these are some data from some of the studies where PSA was not shown to be reliable and multiparametric MRI was shown to be reliable. But even the sensitivity of multiparametric MRI in this setting is lower than the sensitivity in patients who were never treated. So in patients who were never treated, prostate MRI is an excellent tool. Again, it misses cancer some of the time, 5 to 10% of the time, but it's still very accurate, close to 90% of the time. But in this setting, it does miss cancer a little bit more than that. So all the patients with focal therapy, if it's been done more scientifically, everybody recommends a biopsy within 1 year.
What does negative predictive value mean?
Negative predictive value means when an MRI says there's no cancer, that's truly the case. Okay, so the negative predictive value of MRI in naive setting, which means without treatment setting, is close to 90%. There was a big clinical trial done in London, again with the same groups, Hashim Ahmed and Mark Emberton, they started those clinical trials to see if multiparametric MRI is better than regular biopsy or not. In that cohort, they said the negative predictive value was close to 90%.
But there aren't false negatives?
That's something 10% is false negative. 10% cases, you will still have some cancer, and NPMRI, multiparametric MRI didn't find it. And that's the exact discussion I have with focal therapy patients. Just because your MRI is negative in, for example, we're freezing your right side, your MRI is negative on left side, that's not a guarantee you don't have a cancer on the left side. But at least we are reassured, we did a biopsy on that area, there's nothing on MRI, at least we're reassured the odds of us missing a cancer is very, very low. Okay. And so the current recommendation is among, and again, there are no hard and fast guidelines. These are few people, dozens of people, 2-3 dozen people sitting together across the world making guidelines for focal therapy. And the current recommendation is to get an MRI at 3 to 6 months, get another MRI in second year, and then at 5 years. Also get a biopsy within first year, and if that biopsy is negative, then you do not need repeat biopsy unless there is real concern. But everybody recommended a full 12-core systematic biopsy within first year of focal therapy. And the reason is there's small chance that you're missing some small cancer. Again, knowing it's better than not knowing. Not everybody gets treatment. If there's a very, very small cancer, it's better to be in active surveillance than not know about it. And the conclusion is data for surveillance is limited, so we have to be a little bit more aggressive in surveillance. We don't know if we are actually helping patients a lot in long term. This seems promising. The outcomes in short term, which is 7 to 8 years, looks really good. Patients tend to do really well, and people are not dying of prostate cancer for this treatment yet. So, but that doesn't mean this is the best treatment available. That's why we're more cautious and we follow our patients very rigorously.
That contrast enhanced one, you actually showed a picture of it before. Is that computer generated, or have you actually put a contrast substance into the prostate?
For MRI, no, we do put
Ultrasound,
contrast.
obviously.
I didn't show actually contrast enhanced ultrasound image. We don't have that at UC. But for MRI, we do inject contrast, and it's not computer generated. Oh, the colors are definitely computer generated. So these are, if you go back, when I showed, yeah, that is computer generated. So the middle picture is what we get from MRI. That's software post-processing showing, that red area is cancer.
Oh, that's DCE, that's the dynamic contrast.
Yes. So that's actually DWI, that's not even contrast. But this could be DC, this is DC, right? Yeah, this is DC, this is contrast image. But you won't get that image from MRI. MRI is not going to give you
That's
blue
software
color.
generated.
Yes, blue color prostate and red color cancer. Okay. So that was second part of our personalized care. The third is clinical trials.
So wait, can we ask a really quick question?
Yeah.
Then? So these new imaging modalities, there seems to be a number of them that are competing now with MRI. There's something called, the high frequency ultrasound, right?
Oh yeah, I did a trial of that this week actually at UC. 29 megahertz ultrasound,
Yeah, right.
which is normal. So megahertz is a way of frequency. And they say higher the frequency, better delineation of lesions.
Right.
A regular ultrasound has 7 to 11 megahertz frequency. This is 29 megahertz. And we tried it this on Monday. We did 4 biopsies using that.
Wow.
And the reason I wanted that ultrasound is because insurance is still giving hard time in getting MRIs in a lot of patients.
Right.
So for the patients where we would not get MRI, is that ultrasound going to be as good as prostate MRI? In my initial experience, it did not appear to be the case.
Okay.
But I'm waiting for we did biopsies on Monday, we'll get the results in 2 weeks. And if the results, and in all those 4 patients, I did find something which was somewhat concerning, so I biopsied them in those areas in a way of the same way we do MRI target biopsy, that was ultrasound target biopsies. If it appears as effective as MRI, then it will make a case of buying that ultrasound. But I was not super impressed, at least at initial impression.
There's another technology which you may have heard of. It's called hyperpolarization with C13 pyruvate. So this is kind of like almost a metabolic kind of way.
Yeah, C13 pyruvate, when I was in NIH, they were working on it and nothing significant came out of it, at least at NIH.
So it doesn't have way better resolution, allow you to.
At least not to the level that we can start offering commercially.
Okay.
But what other people are evaluating is they're evaluating PSMA PET in this setting. And there is some literature coming up saying in focal therapy literature, PSMA PET might be better. And they said MRI is still missing some cancers for these patients. When you select these patients again, we're taking a patient which could have gotten radical prostatectomy and 85% chance of cure in 5 years. We're giving them 54% chance of cure, right? So we're lowering their chance of cure. So we want to be absolutely sure we're finding the best candidate. So they said get an MRI and get a PSMA PET before you make a decision for focal therapy. But again, with the way US healthcare is, it's going to take 10 years before we start getting PSMA PET or something like that. It's not even available at most places. And the places where they're available, the hospital has to undergo a contract with Medicare to get that PSMA PET. And I don't think it's going to be universally available anytime soon.
Thank you.
So the fourth part of our care is clinical trials. So this is one of the trials which we have currently, and there was a great need for this trial at UC, and this is a trial for metastatic prostate cancer patients. So if you know, we offer treatments for prostate only if your cancer is limited to the prostate. If your cancer has already left your prostate, we would put them on androgen deprivation therapy, and that's it. Androgen deprivation therapy, which means taking away testosterone from the body so that prostate cancer cells don't grow rapidly. Testosterone, male hormone, is like a food for prostate cancer cells. So that was the only treatment. Take away the testosterone and slow down the growth of cancer. And typically, if you have metastatic prostate cancer, when you start an androgen deprivation therapy, the cancer responds for 2 years. After 2 years, the cancer becomes independent of androgen deprivation therapy, and after that, your metastatic disease burden increases, and the median survival, which means 50% of men live only 42 months after diagnosis of metastatic prostate cancer. Okay, so we were not actively treating their prostate, but if there were, for example, kidney cancer, if in kidney cancer, when the disease spreads out of the kidney, we still go ahead and remove the kidney. And that kind of treatment has been shown in other cancers to be effective also. But in prostate, we were never trying that. If the cancer is out of prostate, we were not treating prostate at all. So people have made a case, can we treat prostate in patients who have metastatic prostate cancer and somehow help them? So over the last 10-15 years, a lot of surgeons have taken prostates out in patients where the cancer was already out of the prostate. And it was not part of clinical trial, it was just part of standard care. You saw a very, very healthy patient and you wanted to give him the most chance possible to live longer, and then remove the prostate. And when they did analysis of that data, they found out that patients who were getting their prostates removed, even in the setting of widespread disease, were living longer than people who were not getting their prostates removed. And then recently there's a clinical trial came up which showed that people who were getting radiation for their prostate, even in the setting of disease out of their prostate, were living longer than people who were not getting radiation. So that has made the case that even when cancer has left the prostate, we should still treat prostate. Or I shouldn't say we should, but there might be some benefit in treating the prostate in that setting. So that's what this clinical trial is about. Patients who have metastatic disease, cancer out of their prostate, who are already on androgen deprivation therapy to control their cancer, we're going to randomize them into 2 arms. One is to not do anything, give them the old treatment, which is just stay on androgen deprivation therapy and don't get anything additional, while half of the patients will get either surgery or radiation therapy based upon their preference for the prostate. And the final goal is to compare which arm lives longer than other. So in that cohort, we never had any treatment. And we see a lot of patients who have metastatic, especially young African American men. They are 46, 47, now they have metastatic disease. They're very healthy, they're very strong, but science would not allow us to treat them because, cancer is metastatic. There's no evidence to treat it. But trials like this give us an opportunity to offer them treatment.
A couple of questions. You said that traditionally the therapy was just ADT if it was already metastasized. But now, would you start the radiation or the prostatectomy before the lowering of the testosterone ceases to make any difference?
No, for
In other
this,
words, would you do it while the ADT is still working? Or would you wait until the ADT ceases to be effective?
no, while ADT is still working, we'll start treatment at that moment. Once ADT ceases to work, then it's like unfortunately, it's like a stopwatch. There's nothing we could do after that. So this is still at the time when the ADT is working. Patients are on ADT for 6 months and then they get treatment after that.
And in the case of a clinical trial, there's going to be a fraction of these people that are going to get no special treatment whatsoever.
Exactly.
Even if the special treatment helps. Well, I mean, that's what you're trying to find
The
out.
thing is, if we would know that special treatment helps, then we would not run a clinical trial. There's a signal. There is some evidence that it might help. That's why I changed my words from saying should to might benefit. So it might benefit, but it might not. And we're inducing side effects to these patients. So you're already dealing with a cancer which is lethal and will kill you, and you're getting ADT, which is taking your energy away, causing fatigue, causing hot flashes, and then with that cancer, you put that patient through prostatectomy, cause urinary leakage, and possible injuries to other parts of the body. For what? What if the survival is not prolonged? You're inducing side effects without survival. That's why half of these patients are not getting the additional treatment. And if the survival is not prolonged, there's no point putting these patients through surgery or putting these patients through radiation.
I can save you a lot of money and time, and I can save those people that you're going to put on ADT and tell you that this study is being basically done in real life every day. I was diagnosed with metastatic prostate cancer 11 years ago and cancer of my lymph nodes, and I went through successful treatment, radiation treatment.
Yeah.
I did ADT, I did radiation for 8 weeks, and I did brachytherapy. Then they radiated my lymph nodes. And I'm telling you today, it was very high precision radiation. I have no bad side effects. My sexual functioning is perfect. No urinary issues, and I'm still alive today. And
So
why you would be doing this when there's doctors actively
what was
treating
your
them?
metastatic disease? Just your lymph nodes were positive?
Yeah, lymph nodes.
This is truly metastatic disease. This is where your lymph nodes go high up like that.
The same doctor
So
is
when
treating
we have been
patients
treating
with-
N1 disease forever also.
Yeah, this doctor's treating patients with bone mets and everything else, and
Yeah, and
it's not
exactly.
curing them, extending their life. So why would you put people on ADT and let them die in 3 or 4 years?
Because yes, you know of the patients who have done, even when people analyze the data, yes, people who got treatment live longer. But we're talking about 2, 3, 4 months longer.
We're talking 11
That was
years
the data.
longer.
Are you
My PSA
are you
is 0.006.
You were gonna die in 2 years after that?
That's what they told me here.
Just because a doctor told you,
They were going to put
it
me on
doesn't mean
ADT.
you were gonna
They were
die.
going to put me on ADT until it quit working.
There are
And
people who
that
live
was
for
11 years ago.
there are people who live for 8, 9 years on ADT also.
I can show you 24 people that did the same thing as me and are walking around today. We've had guys here with recurrent cancer after prostatectomies that they radiated prostate bed and didn't work because the cancer spread otherwise. And these doctors are saving these people with high precision radiation every day.
Dr. Struve can.
Yeah, and I think there's surgeons doing the same thing as well. I think there are surgeons who have operated in the setting of lymph node positivity or metastatic disease. So people have been doing that for a long period of time, and yes, you have great outcomes, and you have outcomes that aren't as good. The problem is we have no definitive data outside anecdotal patient reports that have done well that this is what we should do. The Europeans are ahead of us. They published the Stampede study that Dr. Sidana had just mentioned. And it turns out that men who have low volume metastatic disease, and like like Dr. Sidana mentioned, this is bone metastases more so than just lymph node metastases, which is a different mechanism of metastatic spread.
Sure.
If they have low volume metastatic disease and they got treated to their primary site, they lived longer. But the guys who had high volume metastatic disease didn't. And so this study is going to answer this question in the United States. And unfortunately, you probably had a good insurance provider, and many of these people have good insurance providers. But if we diagnose a patient with metastatic disease and say we want to treat their primary site or give them aggressive therapy out above and beyond just ADT by itself, their insurance company may say, no way, you don't have the data. Prove to me that that's going to be better. And I could say, Kevin from the Prostate Cancer Support Group says it worked for him. And they would say, I don't care.
This doctor has full insurance coverage, been doing it for 25 years.
So,
And, I mean, it's...
the other advantage of running this trial is, yes, you got radiation treatment, we know it worked, right?
You can
There-
get
there-
the
there-
data and save all this time and trouble and people's lives.
No, let me finish it. So, there's our first patient who is on this trial. His AUS symptom score is a score for urination. The highest it can go is 35. 35 is when you're really miserable. Okay? His score is 35. I picked up phone and asked 10. This patient got randomized to the treatment now. What treatment should we do to this patient? Right? He's already miserable. He has a metastatic prostate cancer. Yes, radiation does work in some patients, and it may or may not work with him. If we know the answer definitively, we would not be doing the study. We don't know the answer. It may or may not work with him. And he's already miserable, metastatic prostate cancer, on androgen deprivation therapy. If we had done radiation on this patient, he would be even more miserable. Not everybody is radiation candidate. So he is getting surgery, he's getting his prostate removed. Because that would make sure his urinary symptoms are better controlled because the prostate is big. So again, radiation is not the answer for every metastatic prostate cancer patient because they would not be eligible. If they are not eligible, should we not treat them? This at least offers an
You're not treating them, you're putting them on ADT until it's no longer functioning.
But this trial will also offer another opportunity for them, right? It will offer an opportunity for surgery for them. They would not have gotten surgery at all. Nobody, even after this trial, very few surgeons will be brave enough to operate on metastatic prostate cancer because they are tough surgeries. In community, everybody wants to do a prostatectomy which takes 2 hours. These surgeries don't take 2 hours. They take longer than that. And but at least surgery will be an option for those patients. Right now, surgery is not an option for those patients.
There's really never a large, and this isn't a national clinical trial through the SWAT. There is never really a clinical trial where that is allowed to proceed if there is not thought to be equipoise between the two treatment groups. There are multiple levels of safeguards to make sure that we are not randomizing patients to what we would honestly consider to be a inferior treatment. So this sorts of things gets vetted through the National Institutes of Health. It gets vetted through each institution's institutional review board, where you have community members, physicians, basic scientists all sitting on there, making sure that there's equipoise and that it's a reasonable study. There's data safety monitoring committees. And if during this study, let's say they get to 600 patients and they see that there's a clear benefit to the addition of local therapy in this study, they will stop the study because it is no longer ethical to continue to randomize patients on a study like this. So we clearly, as a scientific community, still believe that the jury is out. And yes, we know that there are reports of patients like yourself and others who have been treated by this physician who have had excellent outcomes. We need to translate that across the country, and the way we do that is with studies like this. So this is open across the country where we can get men from wide backgrounds and hopefully move the needle. Because right now, 99% of men who have metastatic prostate cancer will only get ADT as their only treatment for prostate cancer. And if this study turns out to be positive, maybe there's going to be more guys like you 11 years later who are doing great.
Well, I've been here in this group for about 10 years now, and I would say 30 to 40 guys in this group with metastatic prostate cancer, maybe I've helped convince or at least point them in the right direction have gone and sought treatment, actual treatment for a cure instead of just ADT for living with bad side effects for a couple of years.
Yeah.
And, you know, the data is there. I mean, this guy publishes papers and studies and has for 20 years.
I think this, again,
It makes me almost laugh.
Question.
In a way, it's sad that people are going to die and suffer when there's readily answers today for them to be treated. Not in Cincinnati, I admit that.
this is not a Cincinnati trial. I don't want you to conceive this is our trial. This is a national trial running at 60, 70 sites. We're just one of the sites. We did not think about this trial. So there's not that bias in our mind if you think we thought about this trial. This is a national trial which has gone through rigorous scientific, the standards and have been proven to be something which a question needs to be answered in the logic world. I'm pretty sure some patients do get treated, but then there are a lot of patients who don't get it.
I have a question about the design. You've had 19 patients screened and only 2 enrolled, so you've rejected 17. And of those 2, 1 may only get the control treatment, which is basically no special treatment. What is the...
This did happen actually. One got treatment, one got controlled. Now,
What is the
pre-screening means
107?
they might not be ready yet. So the randomization happens at 6 months for this trial. You have to be androgen deprivation therapy for 6 months before you get randomized.
How many...
And
it says they're 107/1273, which I assume was too long to fit on the goal line.
That's the, no, 1070 to 1273 is actually national numbers. The trial,
So what will the 107 be?
107 people have been enrolled nationally on this trial. UC has enrolled only 2 of them.
Oh,
So 105 patients have been enrolled.
So
These are 50,
this-
60
what's
sites.
your
Just
total
open
number?
it.
Is this going to be a really significant number of people?
1273,
Oh.
that's the number. That's the national number, 1273. All the sites, you can't get 1273 patients at UC. That will take like a century.
Well, when I say you, I mean the clinical
Yeah.
trial.
Yeah, so 1273 patients nationally for this. Total 107 patients have been enrolled. Of course, the bigger sites will be putting more patients, like UC will be putting less patients on, but like we're trying to do our part on. But if this shows, and again, it may not show clinical benefit. I think some of us will be all here when the results will come out in 15 years, I hope. It may not show benefit. Just don't, for example, I'll tell you, there's no evidence of prostatectomy in recent 8, 9, 10 cancer. Everybody gets prostatectomy, right? There's no level of evidence doing it. Yes, we feel it benefits, we do it. And again, this trial may or may not show the benefit.
This is a subject of controversy, and the doctor he's talking about, we all know who he is, but he has not done a randomized clinical trial. I mean, he may have helped a lot of people, but we don't know, and that's not a randomized trial. But maybe somebody should do a retrospective trial. If there are enough people
Yeah.
who've had this experience, why don't we get more
They
retrospective?
did retrospective. That's where the benefit was seen. That's why they're doing randomized trial.
Okay.
So if you do retrospective, you can't go to insurance and say that retrospectively showed benefit. That's one reason. Secondly, there are numerous examples in scientific world, not urology, other retrospective analysis showed things to be really good. Then they did randomized trials, no benefit. And those treatments have fallen out of favor. So there's a lot of biases which goes in retrospective. For example, I treat patients with, even without this trial, I was doing prostatectomy patients, right? But I'm selecting my candidates. I'm selecting marathon runners, and I'm selecting those patients that are going to live anyways with metastatic
Those
prostate
patients
cancer.
that
If they're very healthy, very healthy, I'm putting only those healthy patients. So what this trial answers is, any XYZ random patient, regardless of, like they don't have to be top percentile of their health, is treating prostate going to help them or not? Maybe when you got that treatment, you were epitome of health. And they said, yeah, this is the patient, we should treat more aggressively. But not every patient would get treatment. And if you're not epitome of health, would you still need prostatectomy? Would prostatectomy still help you or not? That's what this trial is going to answer.
That S1802, that's a code number been given to this trial.
It's
Who's
SWOG.
actually conducting it, NIH or something?
No, it's an organization called SWOG, SWOG.
Southwest Oncology Group. It's just a large
It's a big-
collaborative national group. And 1802, usually the first two numbers are the year that it was started, so 2018,
And the second trial of that year.
probably.
And this is phase 3. What happened in phase 1 and phase 2 that allowed you to go to phase 3?
So they didn't do phase 1 and phase 2 for them. It's not an experimental treatment enough for us to put phase 1 and phase 2 in, right? We know prostatectomy, we know the side effects, we know how it works. So they directly went to phase 3 trials. Because phase 2 trial would not give, phase 2 trial may show some benefit, and like if you treat 5 patients and with radiation and their benefits, that's not enough evidence for us to start treating every year 30,000 patients with metastatic prostate cancer, start treating them. Is that just because 5 patients did better, we can't put 30,000 patients through treatment which has side effects. These are not benign treatments in metastatic prostate cancer patients. I had seen patients get rectal injury in surgery. Again, it can happen even in benign, in less aggressive prostate cancer, but when you're dealing with this prostate cancer, rectal injury, colostomy bags, multiple surgeries, these are not benign. The prostatectomy is not benign in this setting. Prostatectomy is very high risk in this setting. So we want to be absolutely sure we're doing the right thing for the patient.
Does radiation also lead to colostomy bags?
Not necessary, but radiation in this setting might be a little bit higher risk than radiation in other settings.
So I understand what that metastatic, that means it's gone to the lymph nodes and spread the lymph nodes?
It's beyond just lymph nodes. So if your cancer is limited to the lymph nodes in the pelvis, that's not metastatic disease
Okay.
for the purpose of this trial. Yes, as a urologist, you say you have cancer out of your prostate, and you have, again, people use whatever terms they use, but that's not truly metastatic. For this purpose of trial, your lymph nodes have to go beyond your pelvis, up in your belly.
Okay.
Or you need to have a bone disease, bone metastatic disease.
Can you tell if a person has bone cancer from a bone scan, or do you actually need a bone biopsy?
You can tell from bone scan. You can just joke. If somebody has evidence of prostate cancer, a relatively high PSA from bone scan, you can make a calculated guess that's prostate cancer. Because bone biopsies are notoriously inaccurate. Even when they're
Oh, a
scanning.
bone biopsy is inaccurate, just
Yes.
because it's so localized, right?
Exactly, so localized, difficult to localize, and a lot of time you just get the bone tissue. Unless it's a big lesion. So this is just another option for patients which we have not been treating so far. The other thing is not every doctor has guts to go against scientific teaching, right? Scientific teaching says do not treat these patients. Not many physicians, especially people who are plain urologists and not urologic oncologists, are not gonna go against the scientific teaching because medical legal implications are huge here. You treat a metastatic prostate cancer patient and now his problem, that's probably not defendable in court. So these are more key eligibility criteria for these patients. But the most fun thing is you have to have only less than 6 months of ADT. If it's more than 6 months of ADT, you cannot go on this trial. The step 1 is registration, then you start ADT after that, and if patients who have response, only they get randomization. Patients who don't get response from ADT, they stay on ADT. They do not get the new treatment. The other trial is, this is Dr. Verma's trial, it's an EOVIS trial. Typically when, this is not something very burdensome for patients, but this definitely helps in research, and I would like to invite you guys if you can help out with this trial. So typically when we get MRI, we give a dye called gadolinium. Okay, gadolinium has been used in MRI, shown to be effective. Dr. Verma's hypothesis is there's another dye called gadostate that's used in liver cancer. And the hypothesis is that dye might be even better than what we have for MRI right now. Okay, so she is looking, and we are looking for 50 patients to test this dye and see if this dye is going to be better than the one which we currently use. And so it's just an MRI, no intervention. MRI is the intervention here. MRI is covered by research, so it's not going to cost insurance. But the criteria for patients is they need to have a regular MRI passed at some point.
They need to have a,
Need to have a regular MRI in the past.
Oh.
So people who have prostate MRI and had biopsy showing cancer, only those patients are eligible for this trial. This is trial as a trial enrollee. It would not help you guys at all or help any patient at all. This is more a trial to see if this contrast agent is going to be better than regular MRI. So anybody who has history of prostate cancer and had MRI and had that targeted MR guided biopsy, they can, if they enroll for this trial, they get a free another MRI, basically.
quick question, you know, gadolinium has been a little bit controversial because if it's not properly chelated, it can cause toxicity. Do you know anything about the one she wants to test, gadoxetate, whatever it's called?
Yeah.
Do you know anything about its,
It has some liver toxicity, but other than that, I think it does not have the same toxicity as gadolinium in terms of the. So gadolinium is, I don't know, you know.
So, gadolinium can injure, or in patients who have renal failure, meaning their kidneys don't work very well, gadolinium is not safe. I think what you're mentioning though is what's called gadolinium deposition. So that's where a patient gets gadolinium for an MRI scan. Gadolinium gets deposited in our tissues. Not all of it is excreted back out. And we don't know if that causes any harm. We've been doing MRI scans for the past 30 years and we cannot point to any harm that has caused. So there is that concern, but so far that we know, gadolinium is completely safe, and depositing the gadolinium into the tissue, we don't think it causes any harm, but clearly there's things we don't know about medicine and about these agents. Eovist, I think, is also a similarly very safe compound, and I don't know if Eovist is also deposited within the tissues. I'm not sure on that. But both of these, as long as kidney function is good, are thought to be very, very safe contrast agents.
It's used in standard of care in other organs. It's used in liver, for example, and it's safe. The only thing is people don't use it for prostate. And the hypothesis is that this might be better for prostate. It may or may not turn out to be better. But these are 50 patients. We're looking for patients who have localized disease and diagnosed by fusion biopsy with MRI. And we're also looking for patients with advanced disease and to see if this picks up advanced cancer better than gadolinium. The patients with metastatic disease or very advanced disease, if they got MRI for one reason, and then they can go on this trial to get second MRI. And again, the purpose of this is not going to directly help the patient at all. This might help future patients if this is shown to be beneficial. And then before we go to Dr. Struve, so this is on Dr. Struve's trial. This is on prostate. We have another 2 trials which are coming up in patients who were on ADT and now ADT is not working. Second line therapy after ADT. That's called castrate-resistant prostate cancer, where the ADT, androgen deprivation therapy, stops working.
but it's not metastatic.
In metastatic setting. This is he's going to review that trial. But these are the other 2 trials are upcoming: metastatic castrate-resistant prostate cancer who have failed ADT. Okay. So I'm going to give it to Dr. Struve.
Oh, I see, prostatectomy, okay.
This is a different story. All right. I'll be very brief. But I do want to recognize Dr. Sidana real quick. So I think we're very fortunate to have Dr. Sidana here in Cincinnati. Prior to him coming here, we you know, he has been instrumental in starting the multidisciplinary prostate cancer clinic. So he approached me and he said, listen, I think we need a clinic where guys can come and hear an unbiased view from both a radiation oncologist and a urologist about their options for prostate cancer. And that did not exist here in Cincinnati until he really spearheaded that effort. So, so I really appreciate that. Also, he heads the GU clinical trials at UC, and it's because of him that you really see these clinical trials, which I think are excellent clinical trials, opening up at UC. And it's really our mission as the academic health center within the region to do the clinical trials, to have the infrastructure to do the clinical trials. And then these sorts of things will make their way into the community. So what we do here at UC will benefit the community at large. And our goal at UC, and I think all of our goals as physicians, is to help the community that we live in, okay? I couldn't be more happy if you get excellent cancer treatment at St. Elizabeth's or Christ Hospital or Bethesda North, wherever it may be. I think we all need to work together to try to beat cancer. And it's our mission to be on the cutting edge of the research, and so that can get out in the community. And then lastly, the novel therapies that Dr. Sidana has brought to Cincinnati as well, the things like the focal therapy, the HIFU, and everything. So I really think that he's been great for us here in Cincinnati. All right, so this clinical trial here. So this is for men who have had a prostatectomy for their prostate cancer and their cancer has come back, meaning their PSA has started to rise again. So once you have a prostatectomy, within a couple of weeks, your PSA should go down to 0 because all of both the benign gland and the cancer part of the gland should be gone. So the PSA should go down to undetectable. Occasionally, the PSA will start to rise again. And then we have to wonder, okay, where is that PSA coming from? So often, or the most common area for recurrence is within the prostatic fossa. So once the PSA starts to rise again, the urologist will generally send you to a radiation oncologist to consider radiation to the prostatic fossa. And that was shown on 3 clinical trials to be beneficial, one of which showed that patients lived longer, the other 2 showed that their biochemical control was better. So now that's pretty much become the standard of care when the PSA starts to rise following prostatectomy, radiation to the prostatic fossa. In 1996, Dr. Bill Shipley at Harvard started a trial called the RTOG 9601 or 02, where he took men who had a rising PSA, a maximum of 4 after prostatectomy, and randomized them to radiation plus or minus the addition of biclutamide, Casodex, which is a different type of anti-androgen drug, for 2 years duration. And the guys who got the biclutamide drug actually lived longer. And this was just published in the New England Journal of Medicine about 3 years ago. And the New England Journal of Medicine is the highest tier medical journal in the world. So it was a big deal. And so that really changed the game. So now we, based on that study, we were saying, okay, we should offer 2 years of biclutamide to every single guy who had a rising PSA after radical prostatectomy. Biclutamide, just like Lupron and these other ADT drugs, has a lot of side effects. It can cause the hot flashes, decreased libido, gynecomastia, breast enlargement, these sorts of things. So it's kind of a nasty drug, and we didn't want to give it if we didn't have to. And on that study, when they looked at the group of guys who had low PSAs, meaning PSAs less than 1, it's unclear whether those guys really benefited from the addition of the biclutamide. And nowadays, we are initiating radiation therapy after prostatectomy in much lower PSA values. So we have high sensitivity PSA assays now. And so we can detect a PSA at a 0.03 value. And sometimes we're initiating radiation at a value of 0.01 or excuse me, not 0.01, but 0.1 or 0.4 or something along that. So numbers that are much less than 1. And so we're unsure whether or not hormone therapy works or is beneficial or is needed in guys with low PSAs. That's where this study comes in. So this study is taking guys who have a rising PSA. It has to meet the surgical definition of failure, which is a PSA over 0.2 following radical prostatectomy, and randomizing them to the new cousin of bicalutamide, which is called apalutamide, which is better tolerated. It's a newer generation of that drug for only 6 months duration. So it's plus or minus the apalutamide drug for 6 months. So they all get radiation, and then half of them will get apalutamide for 6 months, the other half will not. And we'll find out, we'll get the answer to that question for the guys who have low PSAs that are starting to rise after prostatectomy. That's where this study comes in. So I think this is a great study, and will really answer the question that we need. Because right now we're working off data from a study that was conceived in 1996. So this will be the new era, how we treat people in today's time. Any questions about that study?
Just a comment.
Yeah.
11 years ago, I was treated with Castadex, Trelstar, and Avodart 3-drug combo as part of the radiation therapy. So it's been around and being done successfully for many years.
Yeah.
But the side effects are kind of nasty when you get about 20 months out.
Yeah, so Castadex is a great drug. It's been around for a long time. It blocks the testosterone receptor. That's how it works. And apalutamide does the exact same thing. Nice thing about apalutamide, no liver toxicity, so we don't have to monitor liver function. So if you recall, probably when you were started on your Castadex, every couple of weeks you went in to give blood work to make sure that we weren't damaging your liver. And so you have much less of that.
You do have side effects.
Gynecomastia and all this, yeah. Less apalutamide, or less side effects, less gynecomastia with apalutamide as well.
Tell me, if you've had the prostatectomy and it isn't successful and they have the radiation treatment plan and it's directed towards the prostate fascia or whatever you call that, what is that? Like the remaining part of the prostate is still in you or what?
No, it's the area where the prostate used to be.
What it used to be.
Right, so it's the prostate bed, and so it's it's basically from the point where they do the anastomosis, which is where they attach the bladder to the penile urethra. So the prostate used to sit in between those two structures. They bring the two together. That's called their anastomosis. So we treat from right about the anastomosis, about halfway up the bladder, and then along the posterior bladder wall, which is the area where the seminal vesicles used to go. That's the standard prostatic process view.
And then so with the prostatectomy, is all of the prostate removed or not?
Yeah. So radical prostatectomy removes all of the prostate.
All of the prostate.
That's right. Occasionally we get positive margin. So occasionally you get a positive margin, and so that's where some cancer may have been left behind. That's a microscopic margin. So the surgeon, when he's in the operating room, whether he's doing it open or under a robotic surgery, he can't see those microscopic cells. So it's not until you finish the case and a week later that you're getting the pathology results that you find out that you may have a positive margin. So, and in guys who have a positive margin, they're at much higher risk for that PSA to start coming back up.
One of the other doctors that came before our group was talking about radiation after surgery and doing the prosthetic bed. And he mentioned that in his experience in the local area that it's about a 50% chance of curing the cancer. That through the numbers of people that they have done without doing imaging and knowing where else it may be, if they radiate the prostate bed, you got a 50% chance of it being worthwhile.
That's pretty accurate.
Is that pretty much your experience?
That's pretty accurate based on the older data. So we have actually pretty robust nomograms nowadays, where you can plug in all the information. So your Gleason score, your PSA before radical prostatectomy, whether or not you have lymph nodes involved, your PSA prior to radiation therapy, and it will churn out a number that's pretty accurate. On average, it's about 50%, but those nomograms are all based on the era when we were treating guys with higher PSAs above 1. We have newer data now that the earlier you intervene, the better. And so I think if your PSA is less than 1, your chances of salvaging or controlling the prostate cancer is much, much better, probably better than 50%, closer to probably 75, 80%.
I guess it'd be better off if you could find cancer before you radiate it, right?
Yes, but unfortunately with such a low PSA, you'll never detect that. We don't have any imaging capabilities that are good enough to detect where that is coming from. PSA less than 1, maybe some of the PET scans, but not really. Yeah.
Dr. Redmond's going to talk next month, but could you tell us where proton beam fits in with what you guys do now? Where that fits into what you're doing these days? Just, maybe it's off topic, we can wait on next month.
Proton therapy fits in on multidisciplinary clinic. So it's one of the options we bring up and Struve. Again, the multidisciplinary clinic is not the treatment option which only me and Tim can offer, right? It's all the treatment options. The proton therapy, even though Tim doesn't do proton therapy, we offer proton therapy to our patients. And it's one of the radiation treatment options, and Tim can elaborate
Yeah,
more.
and I think there may be some members in this room who have seen me in the multidisciplinary clinic and have talked about with them about proton therapy, and they've gone on to receive proton therapy from my colleagues up at the Proton Therapy Center. I think proton therapy is a very valuable tool. It's a good tool for the treatment of prostate cancer. And I think we keep harping on this, or this is a common theme tonight, but we have yet to prove that it's any better. So we have yet to show a single clinical trial that is any better or that its cost is justified. Its cost is about 2 to 3 times as expensive as conventional X-ray treatment. And there's not even a sliver, a glimpse that it's any better in terms of efficacy or side effects compared to conventional X-ray treatment. So I don't push it. I don't push it on you guys. I say if you have the means to do it and your insurance company will cover it, great, do it. If I had prostate cancer, would I do it? I probably would. If my insurance company was not willing to cover it, would I pay for it out of pocket? Heck no. I'd go buy you can probably buy a pretty slick sports car for the price of proton therapy. So I'd do that instead.
Yeah,
So who's paying for this facility up there? Children's Hospital? Are they using it 90% of the time or something?
No, it's actually, there's about twice as many adults that are treated at the Proton Center than there are children. It's housed in the Children's Hospital Liberty campus, but it's a joint venture between UC and Children's Hospital. There is an adult pantry and a pediatric pantry. The adult pantry is about twice as busy as the pediatric pantry. We are unique amongst proton centers within the country that we maybe have 1 prostate patient on treatment at any given time. We, as a group, have decided that this is an expensive resource, and despite the fact that medicine seems like or medical payments seem like an unlimited resource, right? We just keep billing insurance companies. That someday that's going to run dry. And so we have not pushed proton therapy or marketed proton therapy for prostate cancer because it is an unproven and very expensive treatment modality. And we can do it a lot cheaper. What was I going to say? But many other proton therapy centers across the country make their bottom line by treating prostates. So they'll have 75% of their adult patients are prostate cancer because we can give 40 treatments for prostate cancer. That's a lot of money. A lot of money.
Could you address the side effects difference between proton therapy and the standard?
There's been none. There's no difference in terms of side effects, at least in any study that's been done, and they've all been retrospective studies. UC, and actually we don't have this here, but we have this study called the COMPARE study, and this is run by the PCORI. So PCORI is the Patient-Centered Outcome Reporting Initiative or something like that. So this is specifically funded by basically patient groups. And so this COMPARE study, it's a University of Florida Proton Therapy Center, and they have a huge proton therapy center down in Jacksonville. They've spearheaded this study, and it's going to be open nationally. It's going to be open here at UC very, very soon. It's not a randomized study, but what it is guys who are getting radiation for prostate cancer, they get a choice. Do you want proton treatment, or do you want conventional X-ray treatment? If you go on the COMPARE study, it means that we are going to rigorously follow you. So you'll get treatment as per the standard of care. And you get to choose, you and your doctor get to choose what you want, proton or conventional X-ray treatment. But when you go on that study, you're going to questionnaires, you're going to get that done before treatment, you're going to get that done every 3 months, you're going to have all of these things done so that we finally will get outcomes data. And so 5 to 10 years from now, we'll be able to justify the additional cost of the prostate and the proton therapy. Right now we don't know, but hopefully the COMPARE study we will find the answer. So that's about to be open here at UC. It's open at numerous proton therapy centers around the country. So we're, as a community, we're actively trying to find out the answer to that question, but right now, no difference. No difference.
And
Yes,
this will be one of those studies where there won't be any direct benefit to the enrolled
That's right.
patient.
This is another altruistic study where you are helping future patients that come down the road. Yes?
It seems to me like there's enthusiasm among people that have undergone proton therapy in that, for example, that I don't see with other therapies. There's a website, Brotherhood of the Bubble.
The balloon. Brotherhood of the balloon.
Yeah.
And there's another one called Bobtails.
Yeah.
And so I'm saying, why are these people that have had proton therapy euphoric about having it to where they want to share it with friends, when I don't see people that have had their therapies jumping up and down and saying, I want to share it?
Yeah, well, I think it's the shiny new kid on the block. And so people who have traveled out to California and Loma Linda for the past 20 years for their proton therapy treatment for prostate cancer, they share those same stories. And proton therapy centers, people in this room who have been to the proton therapy center, you know that it's a glamorous experience. You walk through the front door, you feel like you're a rock star, and you get the greatest service ever, and people are very attentive to you. It's that way because it kind of has to be that way. It's like basically getting your treatment at a 5-star hotel. So the experience, the patient experience, I think, is overall better. But I really think that it's just the fact that they're getting kind of the new kid on the block, the shiny, the cool new toy type of treatment. There are guys who have had fantastic experience with proton therapy, 0 side effects, and have done great. There's a lot of guys who have had conventional X-ray treatment and have the same outcomes too. So I think it's a great tool. I hope that we use it for every single prostate cancer patient 20 years from now. I'm just not sure if we can justify using it right now.
Isn't there another side to that, Scoop? That conventional radiation treatment, the technology has evolved over the last 10 years, and I'm not sure, well, so has proton beam therapy as well, because now there's pencil beam, intensity modulated and all that. But isn't it true that it seems like, and this is, I haven't read every single study, but it seems like the outcomes for radiation have improved, both in terms of efficacy and side effects, that because the collating of the beams, or whatever, how you basically guide the beam, in other words, real time, whatever, keeps improving. They keep adding more and more improvements, which make for better outcomes.
Yeah, Ethan, you're exactly right. I mean, I think that the difference between proton therapy and conventional X-ray treatment 15 years ago was pretty marked. But now with IMRT and VMAT techniques where we can really bend the dose around the patient's rectum, and we have daily image guidance so we know exactly where that prostate is every day for their treatments, the differences are going to be so minimal. So that's, I'm a local champion for the COMPARE study, so I hope that it's a good study. I hope it does well, and I hope that it proves that proton therapy is better. I have significant doubts. I think it's going to be a negative study. I think what we're going to find out is that conventional X-ray treatment is just as good as proton therapy.
It never occurred to me until they mentioned specifically protons, which is a particle in the atom. When you say radiation therapy, what are you actually radiating with?
Photons.
Electrons or?
No, photons, same thing's coming out of the light bulb.
It's a higher frequency stuff.
Yeah. So, charged particle would be proton therapy, and then photons are just X-rays. So they have no charge, no mass, they're just energy.
Don't you think, as far as the side effects too goes, that proton hasn't been out for a long time? Some of these side effects tend to happen after several years.
Yeah, proton hasn't been in common use for a long time, but it has been out. So we've been treating patients with proton therapy since the 1960s, and then Loma Linda's been doing it since the 1990s. So it's got a sizable track record. particularly for prostate cancer, it's probably more patients have been treated for prostate cancer with proton therapy than any other type of cancer with proton therapy. Yeah.
What about CyberKnife?
Yeah.
I know they're urology groups, that's the latest and greatest. Christ Hospital said maybe we don't need 42, maybe we need 15 or something like that. What do you guys do?
I do 28. So when I trained and when I started my practice, which was only 3 years ago, I was doing 40 treatments for every single guy. Then 2 big studies came out. The Europeans are way ahead of us in all this stuff because they look to try to minimize costs, so to decrease the number of treatments. So they did 20 treatments, and then here in the US we've been a little bit slower to adapt, and we've gone down to 28 treatments. I love the 28 treatment regimen. Every single guy I treat with the 28 treatment regimen does, well, I won't say every single guy. The vast majority of people who do the 28 treatment regimen do just fine. I did a little bit of the 20 treatment regimens, and they were fine. It's a little bit more complex, honestly, with the planning portion of it. And so because it's just easy for me in 28 treatments, and it doesn't seem to be that much more of a hassle to come for 28 visits than 20, that's what I do 28 treatments for low risk, intermediate risk, and high risk patients. They all get 28 treatments. I think CyberKnife is a great treatment. So CyberKnife is 5 radiation treatments, generally delivered once to twice a week. The urology group has a CyberKnife. You don't have to go to a CyberKnife unit to get CyberKnife type treatment. You can do it on any standard linear accelerator device. It's a newer modality. Of all the radiation modalities, it has probably the least long-term data, long-term safety data. However, that being said, we do have about 5-year safety data, and everything that has been published to date says that it's just as good, just as safe, and just as efficacious as 28, 30, 40 treatments, whatever you want to do. So it's highly convenient. So I think it's a very good treatment. We have, at UC, again, we are slow to adapt, mainly because of a cautious front on that, and I think that just stems from our history. So I don't do SBRT treatments yet. I foresee that I probably will. In the next 5 years, I will. I think the safety data will mature even more, and I'll be doing more of it. It's important to note that many places like Memorial Sloan Kettering does a ton of CyberKnife type treatments, so they bought into it. So I think it's a good treatment. It's a good tool. Yeah.
Do you use ADT in combination with your radiation treatment?
In high-risk patients, yes. And then I had a discussion with the patient for intermediate risk disease. That's a very controversial topic, and I was talking about that with a gentleman earlier tonight, that in intermediate risk diseases, it's a little bit less clear whether or not.
Does the data show that you get better results or better outcomes with the combination versus
in high-risk
just
disease?
radiation?
In high-risk disease, absolutely. And in lymph node positive disease and high-risk disease, yeah, without question. ADT is needed.
Can I ask a question about that? Because it seems, and maybe that, from just what I've been seeing, that there seems to be a trend towards shorter
periods,
duration of ADT for as adjunctive therapy with radiation. Is that true?
Yeah, I think so. So right now, the historical standard for high-risk disease is 36 months. I think most of us are coming down to about 2 years. Sometimes if guys are miserable on it after 18 months, I'll like say it's okay to stop after 18 months. I think we're going to find, and that data is forthcoming, but I think we'll find that the sweet spot's going to be somewhere around 18 to 24 months for high-risk prostate cancer. If you're a data purist, the gold standard is 36 months. However, all of the studies that we did that tested the duration of hormone therapy, whether it was for intermediate risk disease or high-risk disease, were in the era when we were using radiation doses that are pretty laughable nowadays. So much lower radiation doses than what we use now.
Yeah. I think the issue, if I interpret it correctly, is that if you look at cancer control, one thing, if you look at overall mortality,
Right.
when you compare In other words, ADT does have some kind of a negative impact.
Absolutely, it raises cardiac risk particularly.
Particularly,
Yeah.
so there's that trade-off,
Right.
right? Okay, and how do you find that out?
By shortening the duration of the ABT, so I think we're moving in that direction there. Yeah.
So typically on an intermediate cancer, how long, if you did the ADT treatment, how long would they do that? That would go on for 2 years.
That's, 6 months is my kind of max duration for intermediate risk disease. That's pretty well tolerated, and that generally doesn't raise or have as big a cardiac risk and the other long-term side effects of the ADT. It's not until you get kind of beyond a year or 2 or 3 that you start to see those.
Should we break and give you guys a chance to talk to the graph?